Hi, my name is Pat Iyer, and this is Legal Nurse Podcast. With me today is Ann Seibold, who is a legal nurse consultant who came to the field from a very different perspective than people who typically join legal nurse consulting. Ann has experience as a clinical nurse working in med-surg and open heart surgery areas. And then after earning an MBA, she joined the process of reviewing the care given to Medicare Advantage patients. You may not know, if you are in the United States, that somebody is watching over the quality of care given to Medicare patients. And if you're outside of the country, you might have a similar process in place or not. She's currently working as an independent LNC business owner, doing some DME reviews, chronologies, subcontracting, and building up her practice working with attorneys. I thought you would enjoy hearing about her transition from the clinical nurse to working in the insurance field and what she did to help make sure that the providers in hospitals were delivering the quality of care that is required according to the standards of care. Ann, welcome to the show.
Thank you for having me.
Let's talk about the role in general that you fulfilled in the insurance company. What umbrella, if we had to put a title to that department, what umbrella does it fit under?
So there are two interchangeable terms that are generally used: utilization management or utilization review. And typically in that, you have a nurse who's called the RN review analysis, who takes evidence-based standards of care and her clinical knowledge to essentially review clinical information coming from facilities to ensure that appropriate treatment was given to the appropriate patient at the appropriate level of care.
And in this review process, were you looking at nursing care? Were you looking at physician care, or both?
So you're looking at the overall care. So you're looking at what did they do for that patient, as in if he had COPD exacerbation, did they assess that patient as you would assess a COPD patient? Did they do the appropriate tests such as ABGs? Were they going to give them the appropriate medications such as bronchodilators and corticosteroids? And did they send them to the appropriate level, like acute or maybe intermediate care, to ensure that that patient was stable and safe?
You know, when I was in nursing and this concept started developing, what I remember the physicians screaming about was, "This is cookbook medicine. How can you tell me how to run my practice?" Did you ever run into that reaction or have to respond to that type of diatribe?
So luckily, within the utilization review, there are a lot of different players and a lot of people who are reviewing it at different levels. Yes, you do have the nurse who's kind of the entry level to ensure that, you know, you have these evidence-based practices that are nationally recognized as appropriate care for that patient. And they are guidelines. So if they met that guidelines, then care was easily approvable. If not, then yes, you would have to send it for a secondary review, usually to the medical director or a doctor, to see if, you know, there was differences because maybe certain medications were contraindicated. So it does meet medical necessity. And yes, there is some pushback on, you know, this is not cookie cutter medicine, but that's why documentation and communication and reviewing standards of care are so important.
And I think what you're emphasizing is that these are not protocols that are arbitrarily established. This is based on, as you said, evidence-based medicine. It's established that this is a safe, effective pathway to take patients down. What I also heard you say, and I want to make sure that our listener got it, was that you as the nurse was the frontline reviewer. You were the person who was looking at the care. You're putting it through a sieve, so to speak. If you envision, I've got my hands up in the air, kind of in a funnel shaped. You're looking for, are those people fitting the standards of care? And the ones that fall out through the sieve are the ones whose care needs to be evaluated further. Did I get that right?
Yep.
All right. And then a physician would be a physician to physician conversation after that. When the nurse is doing that initial review, what is the goal? What is the purpose of that piece?
So the goal is to ensure that the appropriate patient is receiving the appropriate care at the appropriate level, and that reimbursement meets at that level. There is so much waste in the US healthcare system. In 2019, it was estimated that we spend over $1 billion on healthcare. 30% of that was considered waste. So inappropriate levels of care, treatment was performed as outpatient instead of, or could have been performed at outpatient setting instead of inpatient, or it was being overused where people were going to the ER for medical treatment that could have been done by a primary care physician, and even abuse and fraud. So the goal is to ensure that there are checks and balances to the system. Somebody's reviewing that care, ensuring that it meets the quality of care so that healthcare costs remain reasonable and don't balloon out of control.
I think what you said was profound, Marianne, and I'm listening to this in the lens of a person who's not in the United States, listening to this podcast and thinking, how can you waste that much money? And you've given some great examples, but if we took that money and used it appropriately, it's astounding what kind of results we could get in terms of improved healthcare. And yet we are throwing money away in a variety of ways.
And a lot of it is, misconceptions of how to, treat or where to go for treatment. And that's one of the purposes of having the utilization review happening, because within the facilities, those nurses are reviewing to make sure that the standards of care are consistent throughout all parts of the organization. So PE patients that meet standards of care, congestive heart failure patients are getting the standards of care. And if there's things that don't particularly meet, they're not checking off all those appropriate boxes, then there's, discussions, evaluations, plans to improve that quality of care. And on the health insurance side, we're ensuring that when we're paying for that care for our members, they're getting that care that they're paying for, that we are paying for, their co-pays are going for. We don't want them to be paying for higher levels of care that maybe didn't actually meet the standards set. We don't want them paying for inpatient when maybe they could have, gone in for abdominal discomfort and gone into an observational setting instead.
Were there certain diagnoses, you mentioned congestive heart failure for one and COPD, were there certain diagnoses where your department concentrated their attention more? What were some of those bigger issues that you saw patterns, where you saw patterns?
A lot of it was, making sure that the standards and the diagnoses and the criteria that we're using all match up. Because what you see is a lot of times they put a diagnosis code to a specific disease process. And a lot of times you have those disease processes that have some overlapping similarities, or patients have comorbidities, such as, I have COPD and I also have congestive heart failure. Some of those treatments and some of those assessments do overlap. And I might be giving a diagnosis of COPD, but maybe that resolved in the ER. And as a doctor, I'm really focusing on the heart, congestive heart failure. And maybe that's why I'm admitting them for it. But maybe I don't know exactly which one I'm going to put as my primary diagnosis. So those diagnosis codes are paid at a very specific pay. So COPD is paid at a specific rate, and congestive heart failure is paid at a specific rate. So I might put the wrong diagnosis code because I'm not really concentrating on the COPD. I resolve that. I'm really concentrating on the heart failure. So we would have to look over the documentation and say, well, you know what, we can see that, you were treating and looking at both, but the primary reason for your admission, primary thing that you're focusing on, primary thing that you're caring for this patient while they're inpatient is that congestive heart failure. So that is what you should be using.
Mm-hmm. And how far did the protocols go in terms of defining conditions? And what I'm thinking specifically of is, COPD and congestive heart failure, we know affect a large portion of the Medicare population. Were there protocols for less common conditions? For example, somebody comes in with a bowel obstruction from a previously undiagnosed colon tumor. Were there protocols for a whole range of subjects or simply for the more common ones?
So you will hear different standards-based evident criteria, such as Interqual, Millman, or McKesson. And what these are a large standards of specific criteria for specific disease processes. And it's used as a guide to help those healthcare professionals, hospital administrators, staff, and insurance industries break down the disease process into the relatively body system. So if it deals with the heart, there's specific criteria that deals with different complications of the heart. Brain, like stroke, TIAs, different processes there. Lungs, even cancers. Those criteria that I mentioned, they do a great job of ensuring that anything that would require an inpatient observation level of care is listed out. And they even break it down, especially Interqual, into levels of care. That patient came in for that abdominal pain. He meets inpatient because they're going to be doing surgical intervention. The level of care that he's going to be getting will meet these levels of care. So they're really encompass all of healthcare, all of disease processes. There's some things that do, yes, fall out of specific ranges. And that's why you're going to be sending it for a secondary review to your doctor to determine medical necessity. Now, these criteria are guidelines that are really used with the medical knowledge of the healthcare professional, the evidence-based practices, and the understanding of potentially how disease processes can play out.
Well, suppose you had a provider who didn't follow the protocols. What would happen next?
So let's say a provider didn't, follow the protocols, and there's a lot to the review process, and there are a little different nuances. But let's say we are looking at a case, it was submitted to the insurance company, the review nurse is looking at it and saying, they didn't do the interventions for that patient's diagnosis of COPD exacerbation. They didn't give those bronchodilators. They didn't give those corticosteroids. Based on this evidence-based practices, I'm going to have to send this up for a secondary review. So I'm going to ensure that the medical doctor who's getting this case understands that, yes, they didn't meet per X, Y, and Z. Here's the clinical information that they gave me. Here's the assessment of the disease process and the treatment that they did do, but here's where it falls short. That doctor, he or she is going to look at that information and say, can I make a medical determination based on the information that they gave me to either say, yes, I can understand why they might have deviated, or no, I cannot understand, and a negative determination is made. From there, after a negative determination is made, the doctors can do a peer-to-peer where both doctors are discussing the care and saying, this is my rationale, okay, I can understand that, or no, you could have performed that at a lower level of care, and that's where you should have been. After those peer-to-peers have conducted, they can actually do it in a formal appeals process where there's several levels where more information can be submitted, more clinical data usually comes over so that the insurance company can, be looking at it and saying, okay, yes, when you did the formal appeal, you gave me much more information about this patient. And, based on medical necessity, I understand why the patient was admitted. Or no, based on the clinical information you've given me, we're sending it back to the doctor for another more substantial review. And unfortunately, the negative determination still meets where you could have performed that care at a lower level. So that way we're keeping healthcare levels costs lower. We're ensuring that the member or the patient is not paying a higher copay for inpatient stay when they got observational level of care, and that overall it could be a potential education and training process for the facilities to ensure that they are meeting those standards of care, and if not, they're having good information about why they didn't, why they deviated, and essentially, if they have to change processes and grow and learn and do quality assurances, this is another way for them to look at that.
Is it costly to take a case through this appeal process?
It is very costly. And that's why good conversations between the healthcare organization and the insurance is vital. You have those nurses from the facilities and from the insurance industries. They're having those discussions saying, these are the standards of care. These are what we're asking you to submit. Because if things are, not always done timely or effectively, and you're going through those appeals, first level, second level, peer-to-peer, it's taking a lot of the healthcare time. So you have a lot of healthcare professionals tied up in these reviews, and it costs quite a bit of money because you have to think about that time is money. You're having doctors not look at patients, but have a conversation doctor to doctor about what care they did for that patient. You're having nurses review clinical information and trying to see why it was deviated. And it does take quite a bit of time, which adds up to healthcare dollars.
Mm-hmm. And also, if the care is denied, the patient has gone home, the hospital and the physician are not going to be reimbursed for the care that they've already provided. That's costly also, is it not? Before we continue with the show, I'd like to share this special announcement with you. I'm Pat Iyer, and I have with me today Teresa DeWitt Lynch. Teresa and I have been planning a 2-day conference to take place June 9th and 10th, 2022, on the topic of intimate partner violence or domestic violence. This is geared to legal nurse consultants who are interested in building up and expanding their practice to focus on cases where there are criminal charges filed and are interested in learning more about this to most effectively help their attorney clients. Teresa, tell our listener a little bit about why this conference that we're planning together is unique in terms of helping people prepare for the conference.
There's a lot of cases in the criminal court system for which LNCs can be very useful, and a lot of those cases involve injuries or medical issues that can affect the interpretation of injuries or even the formation of injuries during a physical assault. And when you talk about domestic violence, understanding how injuries are formed, different mechanisms of injuries is very important because physical assault is often one of the center points of a domestic violence situation. So the LNC would need to know, how to properly identify injuries and then also how to interpret them within the context of the identified mechanism of injury.
And for the person watching this video who doesn't know your background, can you share how you got involved in helping attorneys with criminal cases?
Sure. I did 20 years in the military. I retired in 2017 from the Navy as a nurse. I started doing sexual assault exams in 2011 in the military. From there, the rest of my military career was spent in education and training. That's my master's background is in education and training, but then also managing different sexual assault forensic examination programs for different military healthcare facilities. And with that, I started to get involved into military court martials, and specifically with sexual assault. And I would serve as a consultant for the sexual assault examinations, interpreting injuries there, and assisting the attorneys in trial strategy and the other aspects of the court martial. And then when I retired, I just shifted those skills into and started to incorporate civilian cases into my practice. So now I do legal nurse consulting work for all types of criminal cases, not just sexual assault, but sexual assault, strangulation, domestic violence, physical assault. I mean, there's a wide variety of cases, like I mentioned earlier, that an LNC can be involved in.
And then in order to help people prepare for the conference, what are you putting together to make their learning even deeper when it comes to evaluating domestic violence cases?
So during the conference, we have three lectures that are based on injuries. So we've got the closed head injury, we've got orthopedic injuries, and strangulation. And understanding the basic concepts of mechanism of injury, injury formation, other elements of a person's health and well-being, and skin factors that affect or can influence the formation of injury in response to a specific force applied to the body is very important. So what we're going to do here, instead of spending the conference time kind of getting that background information and that foundation of injury identification and interpretation, we'll have information for them ahead of time on different types of injuries, blunt force injuries, sharp injuries, spend a little time discussing bruising or contusions. That way, that information can be directly applied to the topics that we'll be discussing at the conference: the strangulation, the closed head injury, and the orthopedic injuries. And we can use the foundational information that they will learn about ahead of time and actually apply that at the conference. So it'll save some time at the conference and let them actually use that information, put it to work right away.
I'm all in favor of putting learning to work right away, because that gives the application to go with all the theory, and it stays locked in and embedded much better that way.
Yes, I agree. I think having this information ahead of time just makes better use of our time during the conference.
And the link to get information about this program is lnc.tips/DV for domestic violence, lnc.tips/DV. If you are hearing this audio after the conference is over, we will have it available for you in a recorded format. I encourage you to put those dates of June 9th and 10th, 2022 on your calendar so you can join us live, participate in the learning, network with your fellow LNCs, and learn how to provide this type of case consulting to your existing LNC practice. There's a lot of work in this field, unfortunately. Violence against women is a factor that affects the safety and health of women in all strata, all educational levels, all economic levels, and much of it goes on behind closed doors. As a legal nurse consultant, you can help the attorneys who are handling these cases, and both the prosecutor and the defense need the assistance of a knowledgeable legal nurse consultant. So join us and ramp up your skills. lnc.tips/DV. We'll see you there. Now let's return to the show.
So you have to think about, and there's different levels, and it gets a little bit, there's a lot of nuances when it comes to saying denying. A lot of times the insurance company is saying, we are not denying the care. They deserve to be cared for, but we're saying that the hospital provided care that was at a lower level than they submitted for. So they're going to get reimbursed at a lower level of care.
Okay.
So instead of an acute, instead of they admitted the patient to acute care, they're on a med surg floor, and the care that they provided could have potentially been done in observational level of care. So the insurance company is saying, well, what you did was observational level of care, and that's what you're going to get reimbursed for.
And is that a significant difference?
It can be.
All right.
Without getting too much into it, because like I said, every diagnosis is paid on what is called a DRG. So it's based on diagnosis codes that say that this diagnosis for MI costs X amount of dollars. This diagnosis for COPD costs X amount of dollars. And acute versus inpatient costs differently as well.
Mm-hmm. We have financial implications, certainly, as you're describing, in terms of being reimbursed at a lower level of care. We have the appeal costs that you've outlined. This is a costly, time-consuming process. What changes did you see in the time that you were in this role? First of all, how long were you in this Medicare Advantage review process role?
So I did it for about 4 years. During that time, I started as a nurse who actually analyzed the case, and eventually went up to administration, where I had to deal with a lot of different regulatory bodies, administrators, and you get an understanding of how the system works. And really, I can tell you it's all about communication, because utilization management has definitely changed and grown the past 20 years. And as healthcare continues to change and grow, facilities, insurance companies, they really need to, healthcare professionals, they really need to continue those lines of communication and grow and change with it. So when I was doing it, what I had noticed was the longer you dealt with facilities, the longer you talked and got those relationships with your utilization management teams on both sides, the better you understood how to communicate and what information was required, so that you had less pains as you went on. You understood, this is what I need to ensure that we don't get a negative determination on this type of disease process, or, oh, okay, this disease process, a lot of times the standard of care says that we should put them in observation for, several hours to make sure that we're not missing anything. But if at that time we need to make them inpatient, we can, or maybe at that time we realize that they are stable and they can, be discharged home. There's a lot of communication that goes on, and it really helps both the facility, insurance companies, and the overall care for individuals be done at the most appropriate level.
When I finished my master's degree, I went into staff development, and I gained a new appreciation of how difficult it is to teach people across different shifts, across different levels of attention, different levels of understanding, introducing new procedures, introducing new equipment, talking about new standards and new policies. That communication piece, as you just talked about, is critical. And yet it sounds so easy. We teach people what they should be doing, but are they paying attention? Are they even present? Are they integrating? Are they remembering it? Are they referring to it at the time that they need that information? That's all a big aspect of helping people change their behavior.
Yep. And what's good though is you have those evidence-based standards of care that you will hear oftentimes in facilities saying, oh yes, we're using Interqual, or oh yes, we use Melman. And they'll use those evidence-based criteria. And then there's also even regulatory agents like CMS, so Centers for Medicaid and Medicare Services, and NCQA, National Committee of Quality Assurance, who say, there's specific standards that we request. So here are the outlines that your facility has to, on both sides of the fence, insurance, healthcare organizations, meet to ensure that you're doing quality of care and that we have measurements of that care that helps the consumer ensure that they're making the best decisions for them at the right time.
Are these built into the facility's electronic medical record to act as prompts? Or is there some other way that these standards are available to providers?
So CMS and NCQA, so CMS is the Federal Insurance Programs for Medicare and Medicaid, and NCQA is an independent organization that sets quality assurance standards. This is similar to how you would think of JACO, Joint Commission, coming in. They have regulations. You can go to their websites like cms.gov or ncqa.gov, and it is a requirement that these facilities, participate in their relative programs. How they do it is going to be based on the facility, how they're going to implement and how they're going to respond to those requirements, and how they disseminate those requirements to their staff. Insurance industry, what we did was we not only reviewed those requirements, we had those standards of care that we used to evaluate it. We also participated in audits to ensure that we are meeting those standards. And NCQA and CMS, they rate you on ensuring that you're meeting those standards. So CMS, they have a STARS rating where 1 is poor and 5 is excellent. And they're saying, okay, you're meeting these specific requirements. We're going to evaluate and compare it throughout the healthcare spectrum. And we think that you're extremely excellent. So we're going to give you a 5-star rating. And the consumer is going to be able to see that because you're doing such a great job. And then Q, on the other hand, is going to say, okay, we're going to do these measurements such as HEDIS, which is healthcare effectiveness data and information. I know I'm throwing out a lot of acronyms, but they're using their system to rate based on standards across the healthcare spectrum, saying that, okay, you're doing such a great job on these core measures, and you're giving us this information, and we can say, okay, you're doing a great job. We are going to give you a good rating so that the healthcare community can look at you and just make the decisions that they need to make in a uniformed way.
You're describing a lot of standards. Is there ever any conflict between one agency saying you do this and another agency saying, oh, no, you don't do that, you do this instead?
So they do have some different requirements. Like CMS has longer timeframes to submit and review and just give a determination than NCQA. NCQA is a much stringent, they have a lot shorter time period. And usually, especially what we did in the insurance industry, is we went with who had the more stringent. So sometimes CMS requirements were a little bit stringent, and sometimes NCQA had more stringent requirements. And we said, to make sure that we're being the best that we can be, we'll follow the stricter of the two guidelines, or depending on the different levels of care, because they do measure for different healthcare products. We're making sure that we meet it on this side of the healthcare products that we are providing to these patients or this community, versus CMS is over Medicare Advantage Part D. We're meeting their requirements for this specific section. So yes, sometimes it is a little bit of conflicting. That's why a lot of times, you're ensuring that you're what you're looking at, what lines of care you're looking at meets up with those specific requirements. So you will at times make sure that you're meeting a stricter time frame for all of your care continuum, just so you're not going to be out of compliance with anybody.
Mm-hmm. You picked up your head one day and you decided that you were ready for a change and you left your role. How did what you did for those 4 years impact your perspective and your skills as a legal nurse consultant?
So as a nurse, we all use those clinical assessment skills, our critical thinking, and the nursing process that we were trained to in school every single day. We get to understand the quality of care and what should happen, what could have happened, and what should not have happened within the healthcare realm. Those skills to be able to quickly identify deviations or adherence to standards really comes in handy when you are a legal nurse consultant. It almost becomes fluid. You understand what needs to happen in those cases. And if it didn't happen, how those regulations, policies, and procedures could be affected. All skills that as a legal nurse consultant, you need to have. It really gives you the fundamentals to be successful in this line of business.
It sounds like you spend quite a bit of time analyzing medical records for the insurance agency, and you're doing the same type of analysis for attorneys and looking at their cases.
Yes, the whole process is really just making sure that care is appropriate. You're doing the analysis for them in a more cost-effective way because you were trained from your starting of your nursing career until now how to do that care, how to do that as assessments, and how to use all those skills that you've learned when you graduated from nursing school and you go out into the field and you're taking care of those patients in a different way. You're still using all those knowledge of disease process, body systems, regulations and accreditations that you need to be aware of, but it's in a different way. It's in a different process. You're not doing it, in the hospital anymore or, for the insurance company. You're doing it for those attorney clients. Make sure that they have the best information for their case.
What a great preparation for being a business owner, spending your time evaluating standards of care, looking at documentation, making decisions about whether the standards were followed. That sounds like a great training ground for helping attorneys in a different way.
Mm-hmm. Yes, it definitely was.
I know that there'll be people who are listening to this who will want to connect with you, Mary Ann. What would be the best way for them to do that?
So you could go to my website, SeiboldConsultingAgency.com, and it will have all of my contact information, my phone number, and my email address. And that website is SEIBOLD consultingagency.com. So my last name.com.
All right. And Mary Ann's last name is spelled SEIBOLD. Perfect.
Yes.
Thank you so much for sharing your knowledge. I know we only touched on the surface of what we could have discussed in this very important role of regulating standards of care and healthcare delivery in a way that is consistent with quality. It's also effectively utilizing our healthcare resources. You shocked us in the beginning with talking about the percentage of waste that is in the US healthcare system. And it is such a tragedy that we are wasting that much of our healthcare dollar. It sounds like agencies and organizations such as yours were targeting that waste to help make healthcare more efficient, more cost-effective, delivered according to the evidence-based standards, delivered in a cost-effective way rather than utilizing higher acute care services when an observational level of care or outpatient care could have been the better answer for that patient. And then you've also described for us what happens when a provider doesn't follow the standards, and there is a review and an appeal process that can be undertaken and hopefully results in either a coherent explanation about what occurred or perhaps an awakening or an increased awareness of how I could have handled this situation better and what I should do in the future.
Yes, I know it was extremely high level, and we didn't get into all the nuances that come along with these kind of reviews. But I do think that, at least I hope we help your viewers understand the basic concepts and gave them the tools that maybe they can use to do more research on their own. I really think that it's important for all of us in the healthcare industry and to know about what we need to do to improve the outcomes of care across the healthcare continuum.
And on that note, Marianne, I think this is a perfect point to complete our podcast. Thank you to you for sharing your knowledge and your experience and giving us a little peek into the world of reviewing the care of Medicare Advantage patients. And for you who has been watching this on our YouTube channel at Legal Nurse Business or listening on our audio channels, thank you for investing the time to learn about this aspect of care and how Ann Seibold was able to transfer her knowledge in a review environment into using those skills as a legal nurse consultant. Come back next week. We'll have a new guest, new topic, and thank you for being a listener of Legal Nurse Podcast. Welcome to Legal Nurse Podcast. I am Pat Iyer. Ashley Morrow and I have just finished talking. Ashley is a nurse who came from the long-term care industry and decided that she wanted to become a legal nurse consultant. And now, approximately 2 years later, she has a thriving full-time business. I asked Ashley a number of questions in the podcast to pull her secrets for her success out of her. Ashley, what were some of the topics that we covered in your podcast?
We started off with how I prepared, how I set myself up to be able to quit the full-time in a facility to go full-time for myself. I also talked about subcontractors, how I found them, what I use them for, what specific areas. We talked about marketing strategies and the rewards of having your own business, being able to work from home, being flexible, and staying with your family more hours in the day.
You'll want to be sure to listen to Ashley's podcast and understand how she created, very carefully crafted this pathway to bring her into a full-time LNC business in only a couple of years. And if that seems like a short period of time, you're on the right track of thinking. Usually it takes between 3 to 5 years to get geared up to a full-time business. And Ashley did it in a short period with some very careful planning. And she'll share with you how she planned in the podcast, as well as how she markets her business to stay visible. Ashley Morrow and Pat Iyer in Legal Nurse Podcast. Be sure to catch Ashley's show. Thanks so much.